Good morning, everyone here and everyone online and national and international. It's a privilege to be here. So my only disclosure is I do work for the U.S. Department of Veterans Affairs at the VA Greater Los Angeles in L.A. I'm also an interventional cardiac electrophysiologist by trade, as Dr. Bond has mentioned. So I always like to start with this sort of background slide, talking a little bit about just women in the military and women veterans in general, because I think sometimes we're not really aware of how many women actually participate in the military. And what we do know is that women do make up about 16% of the current military population in all branches. And we also know that women veterans will be increasing in their population over the next 25 years, up to 2.2 million veterans total. Sociodemographic-wise, we do know that the largest group of women veterans currently is in the age group of 44 to 65 years old. We do know also that younger women veterans are quite ethnically and racially diverse. 30% of women veterans are Black women veterans, and 10% are Latina women veterans. And when you compare that to the older age group over 65, you can see a huge, sort of very different racial grouping. We also know that the quality of care is improved in the VA system, but we also do know that younger women veterans do have higher rates of delayed care, and there's still racial disparities that persist in the measures that impact cardiovascular disease. So let's take a quick look at the traditional cardiovascular risk factors in women veterans. I don't really need to tell this audience about cardiovascular risk in women in general. We do know it's, again, the leading killer of women overall. Every 80 seconds, a woman dies of cardiovascular disease. We do also know that women veterans, 11% of them have been diagnosed with cardiovascular disease, and that increases with increasing age. But what's more alarming really is that greater than 50% of women veterans have at least one cardiovascular risk factor, and that goes up to about 80% in women over 65 who are veterans. Obesity, active duty people generally are not very obese, but something changes as when they become veterans. And veterans are more obese and meet the criteria for being overweight than the general population and are affected at a rate of about 80%. More women veterans are obese than male veterans, as you can see in that chart. And Black women veterans actually have higher rates of obesity than Black male veterans, and they are twice as likely to be obese than white women veterans. And with mental health disorders, women veterans have an increasing rate of obesity as well. Veterans are twice as likely to have diabetes than the general population. Women veterans generally also have higher rates of diabetes than the general population as well. Some studies have shown a prevalence of about 30%. And again, that increases with increasing age, as you can see. Women of diverse, or women veterans of diverse backgrounds, are again disproportionately affected. Latina women veterans are 4 times as likely to have diabetes, and Black women veterans are 3 times as likely to have diabetes compared to their white women veteran counterparts. And you can see in that chart there that as they age, again, there's more diabetes that affect our women veterans. Dyslipidemia, veterans have more dyslipidemia than the general population. 50% of veterans are affected. Women veterans generally have a lower prevalence of dyslipidemia than their male veteran counterparts, but again, that increases with increasing age so that they become equal after age 65. And we're going to talk about this a little bit later in the talk, but women veterans, again, have poorer control of their lipids than male veterans do. Cholesterol, again, increases with increasing age for women veterans, with Latina women veterans and women veterans who are Asian Pacific Islander having the highest rates, over 50 to 60%. And again, if you have mental disorders or if you have substance abuse, women veterans, again, have higher rates of dyslipidemia, up to 40% in women veterans who have depression and up to 45% in women veterans who use tobacco. Active duty women have, or active duty veterans, I should say, have ideal blood pressure only about 50% of the time. And while veterans generally have less hypertension than the general population does, women veterans generally have much higher hypertension as they age. And over age 85, more women veterans have hypertension than male veterans do, and they have poorer hypertension control. Again, veterans of diverse backgrounds are, again, disproportionately affected. Black male veterans, like the general population, have the highest prevalence overall. You can see that in the chart on the right-hand side, sort of in the grayed out section. But black women veterans have just as much hypertension as black male veterans, and they have way more hypertension prevalence than any other age group or race in the women veteran population. And you can see there, starting at age 45 to 64 age group, 50% of black women veterans are affected, and it goes up to greater than 70% when women veterans reach the age of 65. Veterans use more tobacco than the general population, probably twice as much. Women veterans surprisingly use more tobacco products than male veterans, and they use more tobacco products than civilian women as well. And if you are a Latina woman veteran, you use 3.5 times more tobacco than white women veterans, and they're less likely to be successful at quitting smoking than male veterans are. We're going to hear a lot of this more about cardio-obstetrics from Dr. Rubenstein a little bit later this morning, but we know that if you are a woman who have pregnancy complications, you are, again, at risk for developing cardiovascular disease later in life, up to 2 to 4-fold. In general pregnancies in the general population, gestational diabetes has been shown to have a prevalence of anywhere between 2 to 10%, with hypertensive disorders of pregnancy being up to 8%. But if you are a woman veteran, you have 40% higher risk of gestational diabetes and a 32% higher risk of hypertensive disorders of pregnancy. So those are sort of the traditional risk factors we sort of think about, but there are other sort of non-traditional risk factors in women veterans that we should really talk about. One of these is homelessness. Women veterans have a 4-fold higher risk of homelessness when compared to women veterans. Why is homelessness important? It's important because, as you can see on the right-hand side of the slide, homeless veterans are at increased risk for cardiovascular risk. Homeless women have a higher risk of premature death and more chronic medical conditions than homeless men. And women veterans get sort of caught in this web of vulnerability. This is a great paper that was written several years ago. And this web of vulnerability includes things like military sexual trauma, violence and abuse, unemployment, criminal justice involvement, and those sorts of things lead to isolation, lack of social support, barriers to access that then contribute to homelessness. And the last most important part of this is so that homeless women, veterans, are not only at risk for higher cardiovascular risk, higher risk of premature death, but they have a much, much higher risk of military sexual trauma compared to housed women veterans, and that risk is up to 50%. So let's talk for a minute about military sexual trauma. This is an astounding statistic. When we were doing research for our paper, women veterans experience more sexual assault than civilian women, 30 to 40%, and that range goes all the way up to 90% in some studies, which is horrifying to me. So in this study, where they looked at World War II and Afghanistan women veterans, 90% of women veterans had at least one form of military sexual trauma, and the print is a little bit small there, but that includes things like harassment, coercion, attempted assault, or actual assault. And women veterans have a 3 times higher risk of stranger harassment within the VHA care environments, and that increases their risk of delayed or missed healthcare because they just don't want to be there to try to get their healthcare. And women veterans with military sexual trauma have a higher risk of both depression and PTSD, 2-fold, and then 6 to 9-fold risk of PTSD. Why is this important? We've known now probably for about 2 decades that military sexual trauma can possibly contribute to cardiovascular risk. The latest study actually was just presented at AHA Hypertension just about 2 months ago now, showing that if you have military sexual trauma, that increases your risk of hypertension by 30%. So when you have violence in combat and you have military sexual trauma exposure, that contributes to women veterans having more depression and more PTSD than both their civilian women counterparts as well as their male veteran counterparts as well. So as you can see, depression is 36% in women veterans, and PTSD is up to at least 17%. That's threefold higher than civilian women's. PTSD has been linked to be a predictor of both gestational diabetes and hypertensive disorders of pregnancy, again, increasing that risk by 40% and 30% respectively, again, predicting probably future cardiovascular disease. And then this next study that was published earlier this year, where they looked at about 400,000 women veterans with PTSD and without PTSD, what they found is that women veterans with PTSD had a much higher risk of ischemic heart disease. And what was interesting is that they found that that risk increased if you were younger in age and if you were not white. And so what they found was that the most prominent risk for women veterans were those who were less than 40 years old, who had a risk of up to 72% of ischemic heart disease if they had PTSD, or if you were of diverse racial or ethnic backgrounds. And as you can see there, Black women veterans had 49 to 50% risk of ischemic heart disease, same with Latina women, and if you were an AAPI woman veteran, you had a 66% increased risk of having ischemic heart disease if you have PTSD. So why is this? We don't know. I think that's what the hard part is about studying women veterans' cardiovascular disease. We're just sort of identifying the risk factors at this point. We haven't really understood why it might be or what the causes might be, but we've touched a little bit on some of the reasons. Women veterans tend to lack social support when compared to male veterans. They don't have people to accompany them to their health appointments to help them take their meds. They're more likely to be homeless. Again, they have a lot of military sexual trauma. They have mental health disorders, but there's other things like women veterans have trouble being able to participate in things like exercise programs and smoking cessation programs, many times because, again, they don't want to be in an environment where they have to exercise in front of dudes, right? So they want to have their own exercise programs. So what about treatment of cardiovascular disease in women veterans? So this was a nice study, again, just released earlier this year, looking at a cross-sectional cohort of 150,000 veteran patients with premature cardiovascular disease. And what they found is, surprise, surprise, women veterans are less likely to receive guideline medical therapy, 35 to 55%, depending on if they had premature CVD or if they had extremely premature CVD. But what was interesting that I want you to pay attention to is this that's in green on the right-hand side of each chart is that if you are prescribing women veterans statins, they are adherent and just as adherent as men are. The interesting part of the study that surprised me, because I really expected to see more disparities within this group, because this group has published on this in the past decade about statin adherence and statin prescription. They found that Black women veterans actually get higher or more prescriptions for ischemic heart disease, premature CVD, as well as extremely premature CVD. So that was unexpected, but they still said that, of course, there are still disparities that persist. Procedural treatment, this is data that comes from 2015 that was published in 2017, so we haven't looked at this in quite some time within the veteran population, but if you pay attention and see that no matter if you're younger or if you're older, or if it's for chest pain and angina, or if it's for heart failure, women veterans across the board receive less invasive procedures than male veterans across all age groups. So what do we do about this? What is sort of the roadmap? I found this picture and I thought it was pretty apropos. It's sort of a long and dusty road, but at least we're starting, right? So we're here. You are here. We have now recognized that there's an issue and that risk factors exist and they're much higher than what we expected. The next step really is providing education to both patients and clinicians so that we can provide tailored screening and prevention, and then hopefully do a ton more research so that we can really provide informed, comprehensive treatment for our women veteran population. We've already started on this road since 2012. The VA has partnered with the Go Red for Women of AHA to bring awareness to our women veteran population, but I feel like that relationship could be a little bit more robust. The other thing that we really ought to be doing as cardiologists, even within the VA system, is really going to our colleagues in the VA women's clinics, where really that's where women veterans often get all of their care. And we need to really provide them with the tools to be able to recognize cardiovascular risks and risk factors. Because why? Because like this study that was published in the Go Red edition of CIRC this year found that if you include some of these non-traditional risk factors into a risk score, these sort of newer risk scores predict and perform better in women veterans than the traditional risk scores do. What's the current research status? Dr. Hayes touched on this. It's the same for women veterans. Really, the results are not stratified by sex. Women veterans are not included in studies of any sort of cardiovascular disease at all. About 15 to 18 years ago, they did this systematic review. 200 studies on women veterans' health, none on cardiovascular disease. So they formed a VA Women's Health Research Network to try to ameliorate this problem. And so then they repeated the systematic review about a decade later. And while there were twice as many studies on women veterans' health, there were only 11 studies on cardiovascular disease. It's astounding, over a decade. But, so we were able to publish this paper a couple years back. And I'd like to think that we're starting a revolution, but maybe it's just an evolution at least. And we found that since our publication and really publishing in cardiovascular journals about this issue, we've seen now more than 15 publications in the last couple of years, and that's taking into account COVID as well. So here are some of the ongoing research studies. The Warrior trial, which some of you probably are familiar with, it's a multi-center prospective randomized double-blinded outcomes trial looking at intensive medical therapy versus usual care in non-obstructive CAD, looking at MACE outcomes. It's DoD funded. It'll include both active duty and women veterans. The Empower Query, this has been completed, was done within the VA. Again, this is trying to come up with tools that we can use to screen in the primary care population for women's veterans' cardiovascular risk. The PTSD and CVD in women veterans project has been now DoD funded, and it is continuing to look at the intersection between mental health and cardiovascular disease. The one gaping hole that I see, because I am an EP person, I have to be biased a little bit, is that there is a gaping hole about EP, right? So we know for sure that these risk factors do not always just cause coronary disease, but we know now that these same risk factors cause atrial fibrillation. And this has not been studied in the veteran population or in women veterans. And will this translate into AFib? We're not sure, because again, there's only been less than 2% of women veterans who have been included in the AF studies that were done in veteran populations. So this is a nice paper that was done by our own Dr. Mikos right here, talking about how we can improve the enrollment of women and racially, ethnically diverse populations in cardiovascular clinical trials. I think personally that we need to employ these same factors to be able to improve our women veterans' participation in research, using and bringing awareness to the structures that we do have within the VA already, and that includes the VA Women's Health Research Network that can facilitate oversampling of women veterans as well as provide infrastructure support, and then really, using what we do very well in the VA, which is telehealth and digital health, which can maybe decrease some of the barriers that may exist for women to participate in research. So this is our paper. I invite you to look at that QR code, and you can do it from your cell phones, and you can read a little bit more about what we found thus far and hopefully contribute to doing some more research in this area. Thank you.